reform, but we're going to have to peel government out of a lot of this and move back to a market-based system that's going to have some difficulties for some folks.
You are correct that before 1983, many of the hospitals did, and especially religious hospitals, did let people in regardless of their ability to pay. But not all did, and especially if those laws were repealed. Are you suggesting that the hospital would have the right to let that person die if they were not able to pay?
No, I would expect that we would ratchet back EMTALA so that those are the people you're left dealing with, not the people who come in with a cold, who clog up ER emergency rooms and use those facilities for maintenance health care, which is exactly why people should be taking care of health care on an ongoing basis. And when something hits, if it isn't life-threatening to them, then they need to live with it. That's the consequences of their choice.
How do you come to do that?
Care health care on a regular basis. But if they are going to the hospital to take care of health care, and I'm trying to get everything you said together, and we ratcheted back the laws in 1983 saying that the hospital has to take care of them regardless of insurance, and you're saying that they don't have to be forced to buy insurance, right. How exactly are they supposed to?
You know, I'm not speaking in terms of legal compulsion to them to take care of their own health insurance. That's their decision. You know, the average, one group of people that is going to get massively moved into health insurance that's not in it now is younger, healthy people in their 20s and 30s. They've made a financial decision to take the chance on something catastrophic happening versus the cost of health insurance.
And how come you force people to get auto insurance?
Now, in any form of system, there'll be some sort of filtering of who gets what. In a pure free market with no other intervention, that would be dollars. And one plus that we aren't comfortable with as a country, by the evidence I've seen, is that rich people get the new stuff because they can afford it. And what ends up happening is they buy down the price in the development stage. They make it more efficient on their dime. And yes, other people can't get it at that point, but it is financially viable to bring into the marketplace and to then make available to everyone else. What we don't have now, and what we're moving in the opposite direction of, is we're not incentivizing bringing new technologies that are cheaper and more efficient into the marketplace because we get in the way in other areas.
The problem is with any incentivization, there's a lag time. And
you're absolutely right. And I would say that when you move from whatever you've got to something that accepts a little more of the impacts of people, say you go from treating everyone to just treating life-threatening medical facilities, there's going to be a period of time where people are going to have to adjust, and there's going to be there's going to be more time during that period of time. But human beings will adjust. They respond to incentives. And until we have a system that is sustainable, nobody in here can argue that the system we have now is sustainable. Until we have a sustainable system, we aren't going to be able to balance our budget and do all the other things. I mean, look at Greece. We can deal with this on a down slope, or we can just go off a cliff.
Greece's economic situation doesn't really have anything to do with it.
It really does when we're spending as much as we are, and we're building in a bankruptcy situation. We've just had the first downgrade of our debt in history.
Well, that's what happened. You think healthcare is going to take away more from the prison industrial complex than the DEA?